To initiate, the purpose of the HCAHPS survey is to uniformly measure and publicly report patients' perspectives on their inpatient care. CMS has said time and time again that the HCAHPS survey is nationwide and apple-to-apple comparison for hospitals. They come out and they actually do site visits on vendors and hospital organizations that conduct their own HCAHPS surveys to make sure that vendors and hospitals are uniformly not only pulling sample sizes but actually conducting the questionnaires on a uniformly basis. That way the information that is publicly reported is an apple-to-apple comparison, whereas patient satisfaction you have the opportunity to do where it's not an apple-to-apple comparison, it's more of an apple-to-orange comparison. The HCAHPS survey is set up for the sampling protocol. It's designed to ensure that the patients who participate in a survey are representative of all the eligible patients who receive care within general acute care hospitals. Also wanted you to notice that I made footnotes. I would recommend that all CFCs for IACES actually go online and download the HCAHPS Quality Assurance Guideline, because I know that a lot of you at times have questions or just need brief updates about the HCAHPS process or things going on for eligibility and exclusions and things like that. But I've also made some footnotes available so you can kind of actually go right to the information that is provided in the slides. With that being said, we'll continue. The goals of the HCAHPS survey that we hit on are there are three broad goals have shaped the HCAHPS survey. The survey is designed to produce comparable data on patients' perspectives of care that allow objective and meaningful comparisons between hospitals on domains that are important to our consumers. Public reporting of the survey results is designed to create incentives for hospitals to improve their quality of care. Public reporting serves to enhance public accountability in healthcare by increasing the transparency of the quality of hospital care provided in return for public investment. HCAHPS survey outcomes. The HCAHPS survey and its administration protocols were carefully developed by CMS to achieve the following outcomes. To increase the likelihood that patients will respond to the survey, and in order to increase the likelihood, the HCAHPS survey should be the first survey patients receive about their experience of hospital care. To ensure that responses to the HCAHPS survey are based on the patient's own experience of care, proxies are not permitted to respond to the survey. To ensure that the patient's responses are unbiased and reflect only his or her experience of care, hospitals and survey vendors and anyone acting on their behalf must not attempt to influence how the patient responds to HCAHPS survey items. I'd also like to provide you with some information, the use of the HCAHPS survey with other hospital inpatient surveys. The HCAHPS survey should be administered prior to any other inpatient survey. The hospital or its agents must not seek to influence which patients receive the HCAHPS survey or how patients answer survey items. Kind of break down on that information a little bit. It's not acceptable for a hospital or vendors to kind of pick and choose which patients receive the HCAHPS surveys based on information that you may have overheard while the patient was actually in the hospital. I know that that has actually come up at times. IACES does have a do not call flag on the data that we receive, so specifically those patients are automatically excluded. They're also called no publicity patients. Therefore, people in the public persona are not, they can be excluded from the survey, and if someone while they're in the hospital states that they do not want to participate, then they should be flagged not to be chosen in the sample size. Now, that doesn't mean that based on if they had instances or concerns while they were in there and may have mentioned things that you feel like you've already taken care of, because I know with maybe other instances with other hospitals, they've kind of taken it on themselves to kind of manipulate or pick and choose what patients may receive or not receive in the selection of the sampling process. But just to let you know that that is a lot of the reasons that we put this together, to kind of specifically go over what patients are chosen and eligible and excluded and not excluded for the HCAHPS survey. Now, when asking, back to the presentation, when asking non-HCAHPS survey questions, do not use HCAHPS-like responses categories. For instance, if you wanted to put supplemental questions and things of that on there, the response choices should not use always, usually, sometimes, or never. It is permissible for patients to be asked about their hospital experience during their hospital stay or during discharge calls, where this is a normal part of clinical rounds, leadership rounds, or patient/treatment care activities. I know that there's been a lot of discussion. We have to be careful about posting and providing patients with information about the HCAHPS questionnaire and certain questions that we ask. In all essence, it's best to maybe get those pre-approved. We have done that for a couple of your facilities that have wanted to post things or ask certain questions. We got those pre-approved, or possibly they weren't approved from CMS. So it's always best to err on the side of let's getting approval from CMS. But they do lay some examples. That was a new addition to the 2012. They kind of gave us some examples, and I listed some of those below in the next couple of slides that were some things that you should or should not do. Patients initiated or hospital initiation, including the hospital's agent's contact/comment response or communication, whether before, during, or after a hospital stay, must not influence the likelihood of a patient receiving the HCAHPS survey. Questions not permissible and alternative questions. What CMS did in the book, and we just incorporated that here, is kind of gave us some examples. If you look on the left, those are kind of questions that are actually on the survey. And then on the right, what they did is gave you alternative things that you can do in your rounding and things of that nature. You might want to post, or when the nurses come in to ask about the follow-up care or how the staff was doing, they kind of gave you suggestions on things that you can and cannot do. So I listed those for you in this presentation. I don't think it's necessary to actually read over all that, but I just left that there for you to kind of have some ideas of how CMS, things that were and were not permissible. One of the things that I wanted to talk about is the communication with patients about the HCAHPS survey. HCAHPS guidelines allow hospitals/survey vendors to communicate, and I encourage you to communicate to your patients because it may increase the response rate. And I know for some hospitals, you may or may not know that J.L. Morgan and Associates has a flyer that you can use with discharging in order to maybe get the response rates up and things of that nature. However, just as long as you communicate about the HCAHPS survey before or at discharge, for example, hospitals may inform patients that they are going to receive a call about the survey after discharge. That is perfectly fine. They just don't want you to encourage on how they should answer or if they should answer the questionnaire. Certain types of communications are not permitted since they may introduce bias in survey results. In the next slide, I have listed some of those for you. I'm not going to necessarily read over all of them. I thought maybe this is something that you could keep and kind of indicate things that you are and are not allowed to do, that they also have put in the quality assurance guideline this year. The next step we're going to talk about is data file submission. This is the part that we really want to get into, is the sampling process. HCAHPS, for HCAHPS, hospital and survey vendors participating in HCAHPS are responsible for generating complete, accurate, and valid sample frame data files each month that contain all administrative information on all patients who meet the eligible population criteria. Hospitals should submit their entire patient discharge list to the survey vendor. Now, I know that in previous talks or other presentations that the data is uploaded from the hospital to the main office in Nashville, and then every Thursday we actually upload the weekly file. Now, with that being said, at that time, to our acknowledgement, we check everything. The entire population is actually uploaded to us on a weekly basis, and at this time there are no we have no questions or anything that we need to validate about the data. And if so, the data department normally contacts the individual CSCs at the individual hospitals, and at that time, if they need to get John or Mark Matthews involved, we will do that. And I know, for instance, Patty and John came down, I believe, in November, and at the time, just a couple months before that, we actually had an audit from CMS, or actually from HCAHPS, which works on behalf of CMS. And at that time, we went over the review with Jonathan and Patty, and one of the main things that CMS, or on their behalf, that they actually do a very thorough investigation. It's almost like being audited by the IRS, is checking the validity of the data. They basically, with a fine-tooth and comb, check to make sure that hospitals are submitting the correct information, and not only that, if they're not, what are we doing about it, and that we are correctly pulling sample frames. They don't just notice if we are correctly at the time pulling sample frames. They actually have us go back and reconstruct sample frames that we have reported in the past, and basically you have to show them that you came up with what you did, for example, maybe 7 or 8 months ago, that you come up with the same set of patients that you turned in on this time frame. And just to let you know that in that auditing process, that the data department, even on both ends, we just had a home health audit also. We have no issues with sampling or pulling the data to this acknowledgement. And that's very important, because that's where you can get into getting error messages and discrepancies and things of that nature, or footnotes that you don't want any footnotes out there on Hospital Compare. And to note, with ICE, we've been working with you for almost 3 years now, and you can see that we work very hard in trying not to, having to file any discrepancies or having any footnotes come up with data. So we take very good pride and determination in our auditing process to make sure that we are doing, everything that we possibly can to ensure that the quality of the data and the responses are turned in correctly. Now, moving forward, the sampling is a 3-stage process for determining whether a discharged patient can be included in the HCAHPS sample frame. And the first step is that you have to determine if a patient is eligible. The second step is the exclusion process. Because a patient may be eligible, however, there are certain things that may exclude them from the HCAHPS survey. And the third is deduplication. And those are for patients that may have had multiple visits, or people that live in the same household within the same calendar month. Now, the HCAHPS process starts with, again, on Thursday we upload the entire patient population. We identify initially the eligible patients. We remove exclusions. We perform deduplication. At that time, we have the HCAHPS sample frame, and what that means is after you do all that process, you have everybody that at that time can be chosen randomly in order to draw a sample. Now, facility, you all have your own set number of questionnaires that you pay for and would like to be completed at the end of the month. Now, with that being said, due to different bed sizes and different population, everybody has a different possibility or percentage that is being pulled for each facility. So that will differ for any hospital. Now, with that, I try to do basically took the information from the quality assurance guidelines, how they break it down, and I added a little bit more of information with discharge codes and things of that nature, because we do have a lot of questions about eligible and exclusions and things of, who and who are not eligible for the survey. So step A, you send the entire population. Step B, you identify initially all eligible patients. And so you can see that you have your entire population, and out of the entire population, you only have a certain number that are actually eligible, and then a certain number that are ineligible. Now, initially, eligible patients, they have to be 18 years or older at the time of admission, and the way that we determine that is by their date of birth. The admission also includes at least one overnight stay in the hospital, and the way that we determine that is the admit date is different from the discharge date. Now, some hospitals will have a observation flag or something of that nature, but CMS strongly encourages that you also look at to make sure that the admit date is different from the discharge date, because a patient doesn't necessarily have to stay in the hospital for more than 24 hours for it to be considered an overnight stay. They just have to have a different admit date from the discharge date, and is considered an overnight stay. Then one of the other things that identifies eligible patients are the non-psychiatric MSDRG principal diagnosis at discharge. Now with that being said, I will provide further information. However, there are certain ineligible DRGs that make patients ineligible, and we have a list of that, and that's also provided in the quality assurance guidelines to determine what service line to kind of crosswalk which your patients fall under, whether that's medical, surgical, or obstetrics. And then you also have the ineligible DRGs. Now, notice when it says non-psychiatric, there is a psychiatric discharge status, and we will talk about that. However, that does not make just because a patient has a discharge status of 65 does not make them ineligible for the HCAHPS survey. They have to fall under the non-psychiatric MSDRG crosswalk. And the fourth and final thing that we would look at to initially identify if patients are eligible is that if they are alive at the time of discharge. And the only way that we as your vendor know that if a patient is alive at the time of discharge is if there's maybe a flag that is sent later because you found out that the patient may have passed, or afterwards, and at that time we can pull them also out of the sample. However, at the time that we receive the data, we have to look at their discharge code. And if they have a discharge status of 20 or 41, then they are not eligible for the HCAHPS survey. Now, step C, we remove the exclusions. Now, and in this pile, it shows the entire population, the eligible patients, the ineligible patients, and now the exclusions. And I'm going to list here for you your exclusions. Your no publicity patients are flagged. IASIS has a flag, and I wanted to let you know that's how we actually know that who your no publicity patients. Each hospital may do it differently. However, IASIS has a flag for that information. Another exclusion is court/law enforcement patients, and there's two things that you have to look at. If they have an admit code 8, admit source 8, that means that they were admitted from court or law enforcement. They are not, they are excluded from the survey. They were eligible, however, they are excluded because most likely we are not going to be able to get in touch with them. Their discharge status code that we would look for is 21, and that means they were transferred to court and law enforcement. Another exclusion is a patient with a foreign home or address. And the definition of that is found in the Quality Assurance Guideline on page 61. Then the following patient discharged to hospice care are discharge codes 50 and 51. Like I said, all this information is notated on the data. So when we're actually determining people that are eligible or ineligible or excluded for the questionnaire, then we actually have to look at each one of these individual pieces to determine that they are eligible. We have no other way or means of knowing that a patient was discharged to home or hospice unless they are coded properly. And I know that I've been on a couple of conference calls with Patty with a facility because they have a rehab unit in the facility, or they provide their own home health care, or they have a skilled nursing facility, and they were coded wrong. But that does not, if they're not coded properly, then we can't determine, then we have to assume that they are eligible until otherwise. So it's very important that the codes for your patients are being done correctly. Patients are excluded because of state regulations, and we have to go in and actually look that up for each individual state. If there's certain exclusions, and at this time there are, for any state that I'm aware of, any state regulations excluding patients at this time. Patients discharged to nursing homes and skilled nursing facilities. We have to look for the discharge code of 3, 61, and 64. Now, this is one of the major discharge codes that is probably coded wrong, and the reason that I say that is because, and I'll kind of give you a couple of, or maybe one example in general, is that some patients have lived in a SNF for quite some time. So when someone is doing their discharge information or admit source information, instead of discharging them back to a skilled nursing facility, they may choose home, which is a discharge status of 1, because in my opinion, I understand, just based on having relatives in a skilled nursing facility, that at some point in time they permanently go to live and they consider that their home. However, for HCAHPS purposes, it's very important to recognize that may be their home. However, it is a skilled nursing facility, and those patients are excluded, and the proper discharge code should go as follows. And basically, to kind of clear that up a little bit, is even though it's their home, if their discharge code is a 1, then there's a chance that they are going to be selected, because everything about them tells us that they are eligible, and they should not be excluded because they don't have a discharge status of 3, 61, and 64. So that is important. Step D is to perform the deduplication, and as I described earlier, deduplication is for patients that may have been in the hospital earlier in the month, and since we sample your data weekly, for instance, if John Aquino was in the hospital and discharged the first week of April, and then he reappeared later in the month, we would take, since we've already pulled him for his earlier admission, he would automatically be deduplicated for his later admission for being in a hospital for more than one time in a month. And deduplication also for people that are in the same household. And we're not talking about same people who say, for instance, we can have patients that, since I hate to say it and kind of walk back, but you don't see the data, but since a lot of skilled nursing facilities patients are discharged home, are coded as discharged home, they have the same phone numbers. So therefore, when we call that number, I've just confused everyone, because they're not eligible. However, they were coded not properly. So when we actually get the data, you'll have 4 patients that were coded discharged home when they should have been discharged to a skilled nursing facility. but they have the same phone number, so you would think they would be deduplicated. But then when you call the number, or we have to use software when we see the same phone number appear, and they don't, patients may not have the same last name, because you have to use certain things to duplicate people with a medical record number. People that have the same phone numbers, you have to check for last names. It's a horrible process for a married couple that uses their cell phone number or different cell phone numbers in order to use them as a duplication process. So CMS requires that you use different things to perform the deduplication. Now on the next slide, then we construct the sample. From that, we can determine, after we've taken out the ineligibles, the exclusion, the deduplications, then you have the remaining, and at that time, that's when, depending on how many patient population that you have compared to your amount of discharges compared to the percentages in your response rate, determines how many patients that we actually choose for what we call of drawing the sample. And the sample patients, as you can see in the red, are the patients that were chosen for the survey. The eligible patients that were not selected are in blue. Now those patients are what we use, what are left over, and we would use to survey for patient satisfaction. Now for the sampling protocol, I had some slides. Wanted the explanation and references, because I know a lot of CSDs have had questions about patients that they thought were not eligible or were eligible and things of that nature. So therefore, I put this information that we use, that CMS has given to us as vendors to use to determine the population who's eligible, exclusions, and things of that nature. So just to kind of recap, a patient has, in order to be eligible for the HCAHPS survey, they have to be 18 years or older at the time of admission. So for instance, if they come in and they were 17 but turned 18 while they were in the hospital or before they were discharged, they still are not eligible. They're not eligible unless they are 18 years or older at the time of admission. And then I listed before, admission includes at least one overnight stay in the hospital, and the way that we determine that is the admission date is different from the patient's discharge date. The next is to look at the non-psychiatric MSDRG, or what we call the principal diagnosis at discharge. Note, patients whose principal diagnosis falls within the maternity care, medical, or surgical service lines and who has a secondary, and this is the very important part, and this is why I underlined this in red, because I know there have been some questions about this also. The secondary diagnosis does not determine eligibility for the survey. It is the primary diagnosis that we receive determines eligibility for the survey. Patient has to be alive at the time of discharge. Patients discharged to healthcare facilities. Patients discharged to healthcare facilities other than nursing homes who are deemed eligible based on the above criteria must be included in the sample frame. Note, patients discharged to nursing homes and skilled nursing facilities are excluded. That's that was changed actually last year, July 2011, excluding nursing home patients. CMS came to realize that 9 times out of 10 when you call a nursing home, you are not able to get those patients on the phone. They don't have phones in their rooms, and a nurse at a desk answers the phone and is not very willing to help you get the patient to the phone to do the survey. Here I've listed discharge codes, and I showed the eligible, ineligible, and exclusions. Now, for some of you who are familiar with our system and who actually go in and look at your data, when you run a query, you actually see the discharge information listed in a box and question. I can't speak halfway intelligently about that right now. I want to say it's either question C or D. I coded here because I know a lot of people have questioned why patients who left against medical advice were chosen for a survey, and the reason is because they are eligible, and that's why I coded in blue. People that are eligible, you will see these discharge statuses. People that are ineligible, you will see them. You shouldn't see these discharge codes when you run a query, and the exclusions. So, for instance, if you ran a query and you've seen a discharge status or a discharge code came back expired, then that means on our end that they got through the filtering system, and we can't take them out of the sample because we already pulled the sample. However, we are to deem them an eligible population. However, what I'm trying to show you here is, because a lot of you have had questions about who and who are not eligible, and the way that we determine some of these factors, as we mentioned in previous slides, are based on admit codes, discharge codes, and certain flags that you actually are required to send, and MSDRGs. So this is the information that we actually have to look at to determine that on some of the criteria. And then here are the admit source codes. Any patient that is admitted under these circumstances are eligible. The only patients that are excluded are from court and law enforcement. And they are actually eligible, however, they are excluded. I know it, what's the difference in eligible, ineligible? I mean, what's the difference in ineligible and exclusion? But CMS, first you have to determine people that are eligible, then you pull out your ineligibles, then you pull out your exclusions, which basically at the bottom line means that they're not eligible to do the survey in the end result. And I did provide for you the table of the MSDRG codes that we have to use to crosswalk the data. Now, what I did here is, as you can see on the far right, when we get your data, we have to crosswalk these codes, and if they have a DRG of, let's say, 775, then they are eligible for the survey. So, for instance, if we see a 999, then they are ineligible. But remember, we do have to look at the primary diagnosis. We don't even ask for secondary diagnosis from any of our facilities, because that does not determine whether or not a patient is eligible or not. Now, sometimes when you send the data, you may or may not, we or may not have a DRG at the time. Now, if you remember, IASIS used to send their data with a 3-day lag, meaning that they cut the data off on Friday and then we upload it on Monday. Well, when Jonathan and Patty were down in November, a lot of patients, sometimes if you don't have, when we were receiving the data that in such a timely manner, DRG codes were not coded at the time, so we added an additional 3-day lag. And Patty also mentioned that with resources available, we do a better job of getting patients' records coded in a more timely manner. That way, the data is more clean. And what we mean by that is that we should almost have everything that we need to know about a patient to determine whether they're eligible, ineligible, excluded at the time that we receive the data. So, and that has happened. We have seen where, for instance, we were having 40 and 50 missing DRGs a month for some facilities. And what that means is that a patient with an ineligible DRG may have made it to the sample, actually completed a survey, which their survey will not count, even though you still turn it in, but CMS will throw it out. It won't be publicly reported. However, what it did is it took a survey from someone, it put them in the population versus someone that would actually really be eligible, and their scores would actually be reported. So that was the justification of adding more of a 3-day lag, another 3-day lag on receiving the data, was giving coders time to code the data. So we just weren't getting enough clean data from the facilities at the time. So, but I think the only downfall is that we don't start your data as soon. There's a little bit more of a delay. However, we still are finishing within the same timeline. There has been a couple instances that we actually finished maybe a week or so earlier, because I know that was a question on one of the CSC calls, but we have put more efforts in adding that 3-day lag on our end to still finish the data in a timely manner, for your quality improvement purposes for IASIS. Here I've listed the exclusions in a little bit more detail. Note IASIS flags the no publicity patients. Remember, court and law enforcement patients are excluded, and the way that we looked at is the admit source code and a discharge code. Patients with a foreign home address, and I did provide you with more information on this slide. Patients discharged to hospice care will be excluded, and we have to look at the discharge codes of 50 or 51 to determine that. You have state regulations, and then you have patients discharged to nursing homes. Some of this we've talked about extensively, and then we have the deduplication process. So to reduce respondent burden, the eligible patients are deduplicated based on household and multiple discharges within the same calendar month. And then here it lists the deduplication process. Now, talk a little bit about the telephone administration process. Even though the QAG lists some specifics, I'll also tell you a little bit about how J.L. Morgan schedules IASIS data. The data collection for a sampled patient must be initiated between 48 hours and 6 calendar days. And like I mentioned earlier, until a couple of months ago, we were actually had a 3-day lag on the data. Now we've turned it into about a 6 or 7-day lag for DRG purposes. So you definitely meet the requirements of starting the data, or you can't initiate until 48 hours. So we would have no way to ever not condone to that policy, because we don't even receive your data for 6 days. So, and we strongly, with the way that we have our contract set up with ICE is we start your data in a timely manner, usually within 1 to 3 calendar days of receiving that file on Thursday. So we'll never have to worry about starting your data before 48 hours or after 42 calendar days, because if we did either of those things, we'd have to file a discrepancy, and that just falls in line with more paperwork and things of that nature that we don't want to have to do. So as I mentioned, survey vendors must wait 48 hours to make the first attempts to contact discharged patients. This will allow enough time to pass for the patient to return home and feel settled after his or her hospital stay. The HCAHPS survey must not be administered while the patient is still in the hospital. A total of 5 attempts must be made to contact non-respondents. Telephone-only survey administration. Under that, we must complete telephone sequence so that a total of 5 telephone calls are attempted. And in order to do that, they have to be made at different times of the day, on different days of the week, and in different weeks within the 6 weeks. So I know as nice as it seems to get the data on Thursday, it would be nice to call, within, you could make 5 calls pretty quickly if you wanted. There's no question about that. However, CMS puts requirements in order to try to better contact and get patients to actually answer the phone, and that's where the time you want to call it different times of the day. They don't give you necessarily the different times. However, based on the fact that we're open 9 to 9, we contact patients. We have the different time slots of 9 to 11:30, 11:30 to 2 to 4:30, and then 4:30 to close. So we try to make sure that, for instance, if John Aquino is on our patient data, that we try to contact him at those different times of the day until he may or may not answer the phone. And then we have to do different days of the week and within 6 weeks. So normally a week's worth of data, we try to get 5 calls in within 2 to 3 weeks to meet the guidelines of not trying to initially make 5 calls within a week. We try to span it out over but no more than a 3-week process. That's why after we receive the last file, it still takes an additional 2 to 3 weeks, even though we received the first file maybe 4 weeks ago for the month of April. We've already completed 5 calls on that time frame. It's the later time frames that we receive throughout the month that we're still actually calling to meet this requirement. The 5 call attempts must be spanned more than 1 week, 8 or more days, to account for patients who are temporarily unavailable. If it is known that a patient may be available in the latter part of the 42 calendar day collection time period, example, a patient is on vacation for the first 2 to 3 weeks of the 42, then it gives us opportunity to contact the patient closer to the end of the data collection time period. We must use the entire data collection time period to schedule telephone calls. So for instance, if on the 4th call, even though we might be through with your sample, but just so if a patient did say we still have some of the 42 days left, if they wanted us to wait 2 or 3 weeks to call them, then we would have to make that request available. Therefore, that would just delay the timeline of getting your data done. So you do want to go ahead and initiate and get your callbacks done in a timer, because the longer the callbacks extend, the longer that it can take to close your data collection period timeout. Proxy respondents are permitted. No proxy respondents are permitted in the administration of the HCAHPS survey, not even for patients who are critically ill, elderly, physically or mentally impaired, or do not speak the language in which the survey is administered. And here we have listed the 2 administrations of our survey, which are in English or Spanish. Now, I don't want to confuse anybody, because I really want to make sure that everybody understands that you cannot use a proxy. However, CMS does allow, if you call and you do have a patient on the phone, and for some instance they might have trouble hearing, or they want to participate in the survey, they can use someone to help intercept, as far as they can use not help in answering the questions or anything of that nature, but they may need someone to repeat things to them because they cannot hear well or things of that nature. But we are not under any circumstance allowed to take a proxy's responses. So that's more or less no proxy responding to the survey. Someone may assist the patient, for example, reading the question back to the patient, but we have to hear the patient's response, not the proxy's response. So it's a difficult situation. Training has to be involved in order to do that, and we really try to stay away from that. But at the same time, if someone really wants to do the questionnaire and they're just having trouble hearing or things of that nature, then we want to try to accommodate them in order to get their responses. But under no circumstances are we supposed to use someone else's responses. Now, I can't tell you that people don't try to lie on the phone and say that they're so-and-so and things of that nature. That does, but they usually end up slipping themselves up by personal or pronoun references that they make. We have had that happen before. So, because you can't actually see who you're talking to, you just have to take them at face value. But some power of attorneys and things of that nature, especially when you're dealing with the elderly, daughters and sons and things of that nature, try to pretend like they're the patient because they're being, in my information, or my experience, they're being nosy, wanting to know why you're calling for this person and things of that nature. So you have to be really careful and have good, kind of listen to pronouns and things of that nature that they're using. A little bit too much information, letting you know that we've kind of talked about proxy must not answer the survey. However, an individual may assist the patient by repeating. The telephone script. Have had people ask that things about the telephone script. Survey vendors are provided a standardized telephone script in both English and Spanish for the HCAHPS survey administration. The telephone scripts must be read verbatim without adding any other questions or tag questions such as how are you and things of that nature. That's even at the end of the question, at the beginning of the questionnaire. CMS requires that we follow a very strict guideline with auditing and monitoring purposes to make sure that this is actually being done. They want us under no circumstances influencing or changing their questions unless you have approved supplemental questions on the survey. Hospital/survey vendors are not permitted to make or use any other language translations of the HCAHPS telephone scripts. Telephone attempts to reach a patient in the sample are made between the hours of 9 a.m. and 9 p.m. respondent time. Repeated attempts must be made until the patient is contacted, found ineligible, or 5 attempts have been made. After 5 attempts to contact the patient have been made, no further attempts are to be made. Here I've define what a telephone attempt is defined as one of the following. The telephone has to ring at least 6 times with no answer, and or an answer machine has to pick up. The interviewer reaches a wrong number. An answer machine / voicemail is reached. In this case, the interviewer we're not allowed to leave messages. The interviewer reaches a household member and is told that the patient is not available to come to the telephone or telephone number. And at this time, the interviewer must not leave a message with them either. The interviewer reaches the patient but is asked to call back at a more convenient time. Then we would set up a callback time. The interviewer gets a busy signal on each of, for instance, if we call them the phone's busy, we would have to make 3 consecutive attempts, but you can't call back to back to back. You have to at least make it within 20-minute intervals. And at that time, then you can code for the day that the patient was tried at least 3 times, but it was busy at the end of all three attempts. That's the only way that you can actually dial a number more than one time within a day or a time period, and it's considered just one attempt. CMS, I know a lot of hospitals, I'll go back to this for a second, would like to send more than one number to contact a patient. However, when you do that, each time you contact a patient is an attempt, except for with the busy signal. So with that being, if John was in the hospital and he left his home number and an alternate number, a cell phone number, when we called his home number and he didn't answer, or we were told to call his cell, then that is considered an attempt. And then when we call his cell phone, even though we hang right back up and call him and he sends us to voicemail, that is considered 2 attempts. I don't really personally like the scenario there. I've asked CMS to kind of look into that, because I believe if I call his home and his wife tells me to call him at this number, then she's almost guaranteed me that he's going to pick up the phone. That should really be considered one attempt, but CMS doesn't feel that way. Anytime you dial a number, so if you try to give us 1, 2, or 3 numbers, it's considered an attempt. So I could sit down and call John, and there's 3 numbers for him, and if I call all 3 numbers, then there's 3 attempts made in one day, and that's just we're just getting into a whole new bag of worms, and we just knocked out 3 attempts in less than 5 minutes. So it's really knocking the chances out to get, like I said, I personally don't like it. I think an attempt is when you actually sit down there, sit down and actually try to initiate a call with any number that is available, but that's not how CMS reads it. They read it as each number you dial is an attempt. So if we have, at this time we don't, I know IACES has tossed it around about having multiple numbers, but I highly encourage that you don't do that, because you could, if someone has if a patient has 2 phone numbers just on 2 different time frames that we call, you could knock out 4 attempts pretty quickly, which is going to I think will take down hospitals' response rates drastically in doing that. Obtaining and updating telephone numbers. I know periodically, CSCs, you receive these emails from our data department letting you know that we may not have a telephone number on a patient. You have to remember, just because when we get the data, if a patient doesn't have a telephone number and everything else about them tells us that they're eligible, then they are drawn into the sample. And if they don't have a telephone number, then that's giving us 1 less patient, even though they're on the sample, but it's not giving us anything that we can use to contact the patient to get a survey. Therefore, we have to try to use whatever resources we can, and that is you, to get a good contact number for that patient. So if you see those emails, you must know that it's important that you look into that matter in a look into that instance or that patient in a timely manner and get that phone number, because we can't start contacting that patient until we have a phone number. And after a certain attempt through you, we have a system. We're going to send you 3 emails to get that information, and if we don't get the updated telephone number, then we're just going to mark it out as a wrong number, and we're going to move on to the next patient. So like I said, some hospitals within a given week can have 2 or 3, 4 patients that don't have a phone number, and all that's doing is taking away from your chances of someone completing a questionnaire. So that it is important, I guess, with coding or getting the patient's information that you get phone numbers and then you get quality phone numbers. It is required that hospital/survey vendors must use commercial software or other means to update telephone numbers provided. At this time, we are counting on you as the hospital to have that in place, with the fact that you're actually in the immediate area. For hospitals that are in the state of Alabama, we have that software. But if you're out of state, we ask that our hospitals that we're contracted with use what means they have available to get us a phone number for that patient. We have to retain a record of attempts to acquire missing telephone numbers. So therefore, if we're audited and they look at your data and say, well, this patient doesn't have a phone number, where did you try or how did you try with the hospital to get an updated phone number? So all these things, CMS wants you to document and are subject to review at any time. So that's why we do send out the emails and ask that you do look into that for us. Telephone monitoring and oversight, and John and Patty got to see a lot of this when they were here, but it is a requirement that hospital/survey vendors, it depends on, with us, you're contracting through us to do your surveys. We must monitor at least 10% of all HCAHPS interviews, dispositions, and call attempts in their entirety. So that doesn't mean that we just have to monitor the complete surveys or the breakoffs. They us to monitor 10% of everything that is done pertaining to your sample frame. So with that being said, we have to document things of that nature, that is actually being done. And this time, CMS doesn't see any. Now, things fall through the system, of course, and at that time, you put other auditing things in place. So we're always coming up with other new ways of doing different ways of monitoring and auditing and things of that nature. Therefore, the more you do, the less likely you are to have discrepancies or footnotes and things of that nature. So the final thing that I have for you is new for 2012. And normally they have a lot that is actually new for the following year, but this year they were quite frankly short and sweet, with the exception of updating questions, and which means that we have to inquire IT time. Just to let you know, Jeff really loves that time of the year when we have to go in and change all the wording for the surveyors, because remember, the survey has to be read verbatim. There's no new exclusions or eligibility or anything of that nature this year for 2012. However, and I picked this time to throw this out here. Hopefully all the CSCs were able to make it. John, and I'm sure Patty, and maybe you'll have to have a conference call, but I wanted to go ahead and let you know that beginning July 1, 2012, there will be 2 versions of the HCAHPS questionnaire available for the use by hospitals/survey vendors. And what that means now is the survey that we are currently using is called the standard survey. And right here it lists the survey questions. The regular 27 questions has been used since 2006. However, they are going to have a survey called the expanded survey, which they added 5 additional questions. Now, this is optional. You can stick with the standard, or you can do the expanded. Now, but you can't pick and choose the expanded. You either do the standard or you do the expanded survey. You can't just do 2 or 3 questions from the expanded. That's not how it works. So I'm going to leave that with you in your system to decide. Jeff wanted me to mention it at this time. We're not going to, company-wide, we're going to leave it up to our hospitals. We're not just going to swap over to the expanded. We're going to, with your facilities, we're going to let you take a vote. I'm sure that's how we do things around there by democracy. However, with our other hospitals, we're just going to let them decide also if they want to stay with the standard or use the expanded. The HCAHPS expanded survey represents the first enlargement of the HCAHPS survey. They've changed questions, however, they have never added questions. So this will be a first. And I can let you know in the training it was asked, will it ever become, will the expanded ever become the standard? Possibly. Will some of those questions maybe used for publicly reporting of the data? Possibly, but not at this time. At this time, they're just adding the 5. They're giving you the option to use the 5 new questions. In hospital, the questions considered patients' preferences regarding post-discharge health care needs. Patients understood own responsibilities in managing health post/discharge. Patient understood the purpose of post-discharge medication. These are like a brief identity of the questions. However, I will. Was the patient admitted through the emergency room? That information used to be provided through an admit source, which admission did away with a couple of years back. So now they've added it to the expanded survey. Patient self-rating of mental or emotional health. That's going to be a fun one right there when you have to go to ask that question. These are the questions that some of your facilities participated in the mode experiment. Obviously, they didn't wait for the mode experiment results to come out. They just went ahead and added it to an expanded survey. Here I've listed the actual questions. They will pose during this hospital stay. Staff took my preferences and those of my family or caregiver into account in deciding what my health care needs would be when I left. When I left the hospital, I had a good understanding of the things I was responsible for in managing my health. When I left the hospital, I clearly understood the purpose for taking each of my medications. The last set of questions is about you. Please listen to all response choices before you answer the following questions, and then the other 2 following questions will follow under here. Were you admitted to the emergency room, and then in general. So now they're going to ask you to rate your overall health and then rate your overall mental or emotional health. So that'll probably bring up some quite confusion for some of the already confused patients. Now, regardless if you use the standard or the expanded, they have changed the wording of 2 of the questions that will go in effect July 2012. And regardless, no one has any choice of this matter. This is something where they changed the way that something was worded because they got feedback. And honestly, this is going to help tremendously, this right here. They're going to make are you Spanish, Hispanic, or Latino origin or descent more of a yes or no. And if they answer yes, then you read all the choices, because previously we had to ask, are you Spanish, Hispanic, or Latino origin or descent? And then we had to, in one breath, try to read all these responses but most of the time the patient would go ahead and answer, but we still, like I mentioned, you have to read everything verbatim. And this was a mouthful to read. So I'm glad that they are letting the patient answer yes or no, and if they answer yes, then you actually find out if they are Puerto Rican, Mexican, Mexican-American, Chicano, Cuban, or other, because most people answer no to that question, so this will knock off some things that really do confuse and upset patients normally towards the end of the survey. The next change in the survey is, when I read the following, please tell me if the category describes your race. I'm required to, and there's a lot of confusion when you're talking with a patient and you ask them, are you white, and they say yes, and then you have to ask them, are you black, and they say, well, I already told you I was white. They kind of keep going back and forth, but they changed the wording at the bottom where it says, please answer yes or no to each of the categories. So they changed the directional phrases that we can use with the patient, and then we ask the questions. So that was probably due to some feedback. And that concludes our presentation.